This conference will now be recorded.
So welcome everybody, happy Friday, and welcome to part 2 of the webinar Medical Advanced Directives in the Shadows of COVID-19. And today I'm going to be talking about how cultural diversity impacts the medical decisions that our patients and our clients make, so that the more aware we are of how their ethnic background affects decision making, we can best serve them through the decision-making process. So at this time, I'm going to share my screen with you. So why more than ever today with this pandemic is it important for us as professionals to know about how cultural diversity affects the decisions people make? Not just life and death decisions, but everyday medical decisions. And my answer is based upon the fact that the quarantine has really caused us to be alienated. We're not allowed to go out the way we once did. We can't socialize. And so it's also cut off a lot of forms of communication that would otherwise be available to help individuals and families that are going through medical issues and medical crisis situations. So I think that now is an opportune time for us to broaden our knowledge base and understand why this plays a very important and relevant role. And it'll allow all of us to become better educators for the larger community. So throughout this presentation, I'm going to make several suggestions. The first is that I hope that in whatever role you play in the healthcare industry, that you kind of put in check your own belief systems so that you're best able to respect other people's cultural attitudes. My second piece of advice is to be very careful and very aware that you don't impose your own personal belief system on others, that really you work as a facilitator to help them understand the choices and the various possible outcomes so they can make an informed decision. And last but not least, communication skills are important. And I don't think we ever stop learning new skills and how to improve upon the communication skills we currently have. So the best thing we can do is to communicate in a way that provides non-judgmental exchange of information. So before we actually start to look at how different cultures approach medical decision making, we want to understand some basic terms of art. The first one being, what is culture? What does that word mean? Well, it's actually multidimensional, and it includes behaviors, beliefs, and values that affect how a person responds to illness, to pain, to selecting medical care, and whether they comply with the treatment plan. Another very important term of art is the word acculturation. And what acculturation means is it's the degree to which a person still maintains the traditional beliefs of their ethnic group or their nationality. And this to me is so important because those of us who were either born in the United States or perhaps have spent much of our adult life here sometimes fall into the habit of making assumptions that everybody has an Americanized view toward medical decision making, and that's really a misconception. So we have to keep in mind that many individuals hold very strongly to their traditional belief systems, notwithstanding that they are living in the United States. The third term of art that I want to share with everybody is the Patient Self-Determination Act, which is a federal law from many years ago that promotes the obligation of healthcare professionals to educate, to inform, but built within this act is a presumption that every person wants to be autonomous. They want to make their own healthcare choices. They want to determine the course of their medical treatment. And as we're going to see during this presentation, that is not a belief that every ethnic group holds to. So there are also some inherent assumptions built into this law, such as assuming that everybody has a certain level of literacy, which, believe it or not, in 2020 is not true. We still have many people that didn't complete high school, and that certainly impacts their ability to understand, comprehend, or read information about an illness they've been diagnosed with, or to even do research to understand what is available for treatment. So just keep these terms of art in mind as we walk through this discussion together. So the first culture that we're going to be exploring today is the Japanese culture. And it's very interesting that in their value system, the group, meaning the family unit, is given greater weight than the individual. So here's where we see the first contrast between an Americanized view that stresses autonomy with medical decision making, because in the Japanese culture, it's more on what is best for the group, what is best for the family. At the same time, they also in their belief system focus on each individual taking personal responsibility for what happens in their life, which means that they're not looking to place blame on anybody else for what is happening to them. They're not going to avoid and say, well, this is because of something else. So when you are working with a patient or a client of the Japanese culture, the first thing to keep in mind is how do you approach them? And their value system is very much based upon respect. So you want to think about approaching them in a very respectful manner. They don't take well to direct communication, meaning they may not look you in the eye directly at first. They may look down. And so you may have to think about changing what you would normally say to a patient to be more tailored to the person in front of you. Now, in the Japanese culture, the role of decision making is really delegated to the husband. So we see that this is a patriarch-based society. Now, if the husband has passed or the husband is ill, then the eldest son would be given the responsibility for making decisions for other individuals in the family unit, even for the mother or any other siblings. However, there always seems to be a balance within different cultural views, and here what I've learned is that when the husband is passed or not well, although it's the eldest son that everybody looks to, there will be some deference given to the preferences of the wife. So how does this culture approach end-of-life issues? Because that's something we're dealing with more and more today as a result of the COVID-19 virus. So the first thing that I've learned is that the way we view things as Americans or naturalized Americans is again based on autonomy. We might blame the environment, we might blame the food we've eaten as contributing to our medical situation. But in the Japanese culture, they really focus on accepting what is. There is no blame of either the patient or anybody else. They don't look at it as somebody failed in the process. So I think they have a little bit more of a spiritual view of end of life, where they focus more on accepting what is and then making the decisions about what type of care is to be provided. Now, in recent surveys and research, it has shown that there has been a slight increase in the use of hospice services by patients that have either terminal cancer diagnoses or are AIDS patients. But there's still a lot of misconception and misunderstandings about the concept of hospice, as well as about palliative care. So because of the misunderstanding, there is not a strong direction to accept hospice services at the end of life. We've also learned that people of the Japanese culture tend to want to pursue traditional remedies along with our Western medicine. So they don't rely completely upon Western medicine, but they may consider other forms of holistic or homeopathic treatment, which might include herbs, acupuncture, and other methods. Now, in the African American culture, they have two very important values. The first of which is they have a very strong preference for sustaining life at all measures and at all costs. Like the Japanese culture, their value and belief system is also heavily based in respect for the individual, as well as respect for the family. And when you dig a little deeper as to what is the cause or what is the basis for the preference for life-sustaining treatment, it has a lot to do in our country with not trusting the medical profession. And we're going to talk in just a minute about a specific incident that has led to this lack of trust. This culture also has a need for hope. So that ties in directly with the preference to try all kinds of treatment in the hope that there will be a cure, or that it will stabilize the individual and prevent a disease process from progressing. In addition, there is a strong feeling of not wanting to be a burden to their family. So I'd like to take a minute and talk about the Tuskegee experiment. Many people are not familiar with it. It was not included in history books long ago. But during one of the wars, it turned out that the United States military, who was using scientists to explore the possibility of using alternate weapons such as biowarfare, had taken blankets that were being given to African American soldiers who enlisted in the military. And these blankets were being treated with a virus that essentially produced syphilis and other related symptoms. And as a result, these men who enlisted to defend the United States government became very ill and ended up passing this illness onto their wives and children. And so because of this particular experience in history, this has really laid the groundwork for the lack of trust in the medical profession in the US. So we need to be very mindful of this, again, when we choose our words and how we're going to communicate with an African American patient to explain their options for treatment. Now, in regard to accessing and utilizing medical treatment It's been documented that African Americans tend to complete medical advance directive documents less often than other cultures. And especially now during this pandemic, having advance directives is important for everybody, especially if somebody is affected by COVID and it's impacting their respiratory system where they can't communicate or they're on a ventilator or a respirator. We really don't want family members or doctors trying to guess what the individual wanted, what was important to them. So we need to find a way to communicate in a non-threatening, non-judgmental manner as to how advance directives can actually help the patient be assured that what's important to them is going to be implemented as well as respected. Those African American patients that do complete medical advance directives tend to more likely request all types of life-sustaining medical treatment, whether it's for artificial nutrition and hydration or to address what would happen if the vital functions of the body, breathing, and heartbeat were to stop. Similar to the Japanese culture that we just looked at, African Americans are also less likely to ask for and utilize hospice or palliative care. Again, it goes back to the distrust factor. Now, I know we're coming up on the 2020 census, and I think it'll be very interesting for us to see how during the last 10 years since the last census was taken, how have views on medical decision making changed among various cultural views. So hopefully early next year, I will have an updated webinar and we'll talk about those differences. For now, my research is based on the 2000 census and the 2010 census. So in the 2000 census, there were 35.3 million Hispanic Americans reported living in the United States. And as of 10 years ago, it had increased to 50.5 million people. And it's actually the fastest growing ethnic group in the United States. Now, traditionally, subgroups of the Hispanic culture in our country have been Mexican, from Puerto Rico, and from Cuba. But more recently, that growth is actually coming from parts of Central and South America. So we may see some different characteristics depending on the parts of the world people are coming from. Similar to the Japanese culture, Hispanics tend to place great weight on the importance of family, again, focusing on the group and what is best for the group as opposed to just what's best for the individual. So there's a high value placed on caring for one another, and we're going to see in a few minutes how this extends to various levels within the family. So one of the suggested approaches in the research for helping a Hispanic patient understand what their medical choices are is to actually ask rather than immediately provide the information, but take a step back and ask, would you like me to provide you with? Or would you like to make this decision? Or would you like your family to make it for you? And again, that's a way of respectfully and deferentially showing that you are taking into account their cultural belief systems. It may be more likely that the answer you're going to get is going to be that the family members as a group will be involved in making the decision. Now, when it comes to accessing and utilizing medical treatment by Hispanic patients, they have a very positive outlook to wanting care to be provided at home. So this culture is far less likely than Americans to place a relative in a facility. or a community. And this is where we see that understanding, that expectation that the younger generation is going to take care of their elders, the older generation. So it's expected that a mother-in-law, when the father passes, will move in with the son and the daughter-in-law, or the daughter and the son-in-law. And we do see that it's very likely that the daughters and the daughter-in-laws will either leave employment or reduce their employment to be at home and be available to care for the elders, which is a wonderful quality. Studies have also shown, similar to what we saw with the last two cultures, that Hispanics are very limited users of hospice services. So again, we have to be careful how we approach the discussion of hospice. We have to be aware that many people do view hospice as if you are purposely or intentionally killing the patient or shortening the prospective time that the patient has. So we have to be mindful that certain words might trigger a certain emotional response. So here I wanted to just share with you a few terms in the Hispanic culture so you would understand what they mean should you hear these words, and hopefully also help you think about communication. How am I going to approach this person? What am I going to say in order to try to gain their trust and their confidence in me to convey important information that they need to make their decisions? So we want to focus on trust, respect, living in the present moment. Again, Americans tend to want to be in the future, excuse me. We need to be mindful of their religious beliefs and how that impacts their belief about their health and their well-being, and also their belief in fate, that to some extent their fate is already predetermined, and that determines the outcome of their illness. Studies have also documented that Hispanics are very hesitant to reach out for community services. So you'll see toward the end, one of my suggestions is I would certainly encourage various medical groups, whether they're private medical offices, hospice, VITAS, care management companies, to really embrace bringing in employees from different cultures. I think that makes a lot of difference when a patient sees that somebody of their own culture is in the medical profession. It can help create that foundation of trust and confidence and allow perhaps for a better facilitation of information to be exchanged. They're also less likely to tell the patient that the patient has a terminal prognosis. And this is a very unique thing that I also found exists in the Japanese culture. In Japan, for people who still live there or who have emigrated to the United States, when a patient is diagnosed with a terminal illness that cannot be treated or cured, there is an understanding that the doctor will not tell the patient, but will tell either the patriarch of the family or the eldest son. So the rest of the family is aware, but the patient is not. Now, we might be taken aback at that. And again, we have to kind of do a self-check and say, where am I coming from? Am I coming from my own personal belief systems? Okay, it seems that I do. So we have to work through that reaction and try to understand and respect where this other culture might be coming from. Again, we want to be mindful that decisions are more likely to be made by the family as a whole to maintain family harmony and the family unit, rather than expecting the individual, the patient themselves, to be the one making all the decisions about their treatment and the course of treatment. Now, I've been very fascinated for years about the Native American culture, and we're going to see that their value system takes a very holistic approach to healing, to the health process, and that it's very much tied into their spiritual belief and how they see themselves as part of creation of the world. So some suggested approaches, should you have the opportunity to work with and counsel somebody of the Native American culture, would be to, first of all, not be overbearing. And this is very similar to our last discussion about the Hispanic culture, but really to be deferential and to ask, would you like this information? Would you like to talk about this? If this isn't a good time, would you like me to come back? Is there a better time? Is there somebody you would like to sit with us and be part of the conversation? But we have to be respectful not to provide unsolicited advice. So it's really more taking that role of being a support for them. Now, as far as patient autonomy, in the Native American culture, there is a belief that no one person or individual is presumed to think or speak for another. So where we see something very opposite what we saw with the Japanese culture, even the African American culture, and to some extent the Hispanic culture, focusing on the group making the decision. So here, it's not that the elder makes the choices or the patriarch makes the choices. But we do have to be mindful that this is a culture based on respect, on honor. A lot of value is placed on honor. And similar to some of the other cultures, they are far less likely to use hospice services. So if the response is initially no, it may be that that part of the conversation needs to end and perhaps switch to something else that might focus on, well, how can we provide comfort measures? How can we make the home a safe environment to take care of this patient? So the next culture we're going to talk about is tying both Buddhism, which is really a religious observance, spiritual observance, with the Thai culture. And I find that there are a lot of similarities between Native Americans and Buddhism and the Thai culture when it comes to both their value systems as well as how they approach medical decision making. So again, there seems to be that underlying spiritual belief, that tie to wanting to understand how does an individual's actions perhaps produce certain consequences in their life, whether it's an illness, a disease, a change in family dynamics, a change in wealth status. However, unlike some of the other cultures which believe that a person's fate is predetermined and so is the outcome, you can not do anything to change it, here in Buddhism and the Thai culture, they believe the opposite, that nothing is predetermined, that we each determine our own destiny. And so we can possibly change the course of what's happening should we change how we approach it. So one suggested approach is to find ways to empower the patient, to empower the individual, to find their answers within themselves. That's what self-referring means. It means to be introspective as opposed to looking outside oneself or looking to other people for answers or other people for guidance. So this is a culture and a religion that looks to self observation, and self-study. So similar to the Native American culture, they view each individual as needing to take personal responsibility for their own health. It's not to be blamed on another person, whether it be a family member or a doctor, but to see, what have I been doing? What am I eating? How am I acting? How am I treating other people? You know, what is my thought process and my speech process? Is it negative? Is that what I'm creating? As opposed to, am I living and breathing as a positive human being? When it comes to end of life issues, especially for those patients you might work with who have a non-treatable terminal illness, you want to find a positive way, again, empowering them to choose how they're going to experience the end of their life and allow them to be involved in that process. It might be that if a person is in a hospital setting or perhaps in an actual hospice setting, they may want to light incense. They may want a practitioner from their own culture to come in to pray with them. So these are things we want to be open-minded and receptive to. When it comes to how they access and want to utilize medical treatment, again, their focus is tied to the relationship between their actions and their consequences. So it may be that their view that they will express to you is they want to find balance and harmony in the end, but they're not about just treating the symptoms with a drug or a medication. It's larger than that. It's more encompassing. So it's taking that step back and seeing, how does the individual fit into the universe, into that larger macrocosm of the world. So before I take some questions, and I also do want to welcome everybody to share any unique experiences they've had in their professional life, I want to again suggest to everybody that you have the opportunity to encourage that the healthcare profession integrate more professionals of various cultural groups into the work environment. I think that this will help to pave the way for better communication. Also consider, although you might not be used to it or comfortable with it, but invite family members when you see that the individual is not comfortable making the decision for themselves. Ask the patient, would they like the clergy person, whether it's from their church, their synagogue, whatever their religious observance is, or somebody from their community to be part of the discussion. It might give a better comfort level. It might allow you to better convey the information that's available to them. And then, of course, we always want to stress the importance that everybody have ongoing education. Education doesn't stop just when we left school and we got our degrees, but information is always changing and developing. So we can become better practitioners by committing ourselves to engaging in further education. And last but not least, be mindful and be respectful of cultural differences. I think that by doing that, you will learn a lot. You will be a much more effective practitioner, and you really will be successful in guiding the patient to whatever is the best and the right solution for them. So at this time, I'd like to open it up for any questions. I'm going to unmute everybody's microphone. So if there's a question you'd like to ask, or perhaps an experience that you'd like to share that you learned from, it's a great way for all of us to learn by sharing with one another.
So Stephanie, it's been my experience. I'm Cuban myself, and I've obviously had friends and family and that have passed away. And uh, I can speak for Cubans directly. Hospice, unless there's a younger child, an adult child, they're usually the ones that make that decision. But older Hispanics or older Cubans don't even understand the concept of hospice. They just you just tell them it doesn't compute. So it's usually the children of the adults that make that decision. And another thing that I notice is again Cubans, because that's the only one I can speak for. Uh, they have they give so much deference to the doctors. They believe that the doctors can do no wrong. So a lot of times, if there isn't a child of that adult that's in that position, the hospice is suggested, and maybe they don't even understand what hospice is, but it's something that the doctor said, so it has to be the right thing.
Mm. Thank you for sharing. Do you, based on your life experiences, have any suggestions that you could share with the rest of us, knowing
Well,
that?
yes, before I went to law school, I was a trauma nurse, and the one thing that I realized is, as humans, we're all afraid of the unknown, which is pretty obvious, right? Um, and if we don't know what's happening or what the future holds, it's very scary. So my suggestion is education, right? So whenever you're dealing with someone and they don't know what you're talking about, they might say, "Oh, no, we just don't do that," is usually what they say. But I think if they're educated, if it's explained to them and they're made aware of these options that are available, it's something they might consider.
Great suggestion. And thank you for sharing that point about the deference to the medical profession. It's something we all have to keep in mind. Again, I think the longer we've lived in the United States, there is that tendency to just assume that people will listen to the doctor, but they'll also then do their own reading and research. And what you've shared gives us a different perspective.
Jill, you need to unmute yourself. There you
Sorry,
go.
I thought I was unmuted. I wasn't all the way over. Okay, because I wanted to see your whole picture, so I was a little cut off. Okay, so interesting what you said, because, my dad is first generation American. And, so my dad, God willing, is turning 90 in November. So,
God bless him.
he's so adorable. So some of what you're saying, I think has to do with the generation as opposed to the culture. Because like in our culture, and so I'm Jewish, okay, in our culture, it's a lot about the greater good, a lot about, the family unit and so on, and a lot of deference to the fact that if you're in an authority position, right, like whether it's the doctor, the lawyer, the policeman, whatever it is, that is the ultimate. You just defer to that authority. As I call it, I say, like, as we've all become more Americanized, and the culture in America is, more the individual versus the greater good, right? And there's this, especially, right now, and thank goodness, there's more question about, having authority and how we have authority and all that. But in general, I think it's very generational, not more than, but like in simulcast to cultural, if that makes any sense. At least that's
Yeah,
what
I couldn't agree with you more. I think you're right. I think that's why I said that if there's a younger, like you're dealing with your dad, you being the younger child, absolutely. If it was just left up to the older, the previous generation, you're absolutely right. They would be like, oh, well, we just don't do that. But then when you have the children, and if they're siblings, they discuss it amongst each other, and maybe there's even some research done, and it definitely blends in that way.
Yeah, definitely.
Jill, that's a great experience that you've shared, and it kind of ties together what you and Al are talking about, which helps all of us to understand why a lot of people still don't have written medical advance directives.
Definitely.
That
That's
certain
definitely a thing.
certain generations and cultures have the belief they're going to be taken care of by the younger generation. So in their cultures, things are not put in writing. So it is a challenge for us to go from that point to being able to explain why here in Florida and in the larger United States, it helps to have it in writing so that if there is a disagreement within the family, they know which is the person that has permission to speak for this patient.
Definitely.
Yeah, there's no doubt. I could probably count on one hand the number of people that I know that are, Cuban like I am, who have advanced directives like, a living will or a medical surrogate. That's just not even spoken of.
Yeah. And there are some people that, again, putting aside what their culture is, that have a very superstitious view.
Yeah.
That if they make that living will, then something is going to happen to them.
Right. You're opening the door. But I think what Jill said is also very true, that what I just said is couched against the younger generations are definitely making that change. And it's, probably not in our generation, but maybe my son's generation, it'll be much more mainstream.
And you know what? I think we have to also look at and appreciate the beauty within each culture, and why they have the foundation they do. And again, just be respectful, be mindful, and we can find a way to still impart the information if we do it that way.
Stephanie, what was so interesting is that when you go through all the different cultures, and I thought about myself or, my family, we're a little bit of this, a little bit of that, and we really are actually, so it was very well done. I really feel like you brought a lot to the forefront today. I really enjoyed it a lot.
Well, thank you. Is there anybody else that would either like to ask a question or share an experience?
Actually, I do have a question if I'm allowed to ask a question.
Yes.
So, and Al, you could, I'm sure, weigh in on this. So, okay, so let's just say in the Hispanic culture where, they don't want to create these documents. Stephanie, what have you found yourself to be able to do? Because we get resistance from clients who, put a lot of, give us a lot of pushback about, working with an attorney, having to get this done. What do you do to, to get around that? What have you found to be best practice?
There is no one best practice. I'm going to say that up front. You have to look at every person, every situation based on what's happening. What are the dynamics in the family? What is the illness? Where are they in the progression of the illness? I think all of those facts affect how I would approach things. And there are certainly plenty of situations where I've had a conversation with the, let's say, adult child or the adult grandchild. They can understand and appreciate why we should have a designation of healthcare surrogate, maybe a living will for the elder. But then maybe 2 months goes by, 3 months, they haven't made the appointment. And then I get the call because the person is very far advanced in the disease process and now they lack capacity. So we've lost that window of opportunity to be able to write and have the elder sign it. So when hindsight's 2020 and we look on Monday morning as to how the quarterback called all the shots on the Sunday afternoon game, I think my number one suggestion would be to try to invite the people that patient trusts the most, which might mean it's a group of you, the patient, a trusted family member, somebody from the church or somebody from the community that they have a strong connection with, because they may end up then listening to you and then looking to these other people to say, what do you think? And whereas you're the outsider, you have to forget what all your education and experience is. You are the outsider. If you can at least share the information, yet they make the decision because they're taking into account the opinion of the people in their community, you might get them to the point of doing the written advance directives. And that's the goal.
So one of the things that worked for me when I was at the hospital was, again, it goes back to education, was I would say, look, you're in this situation, you obviously love your family and you want the best for your family, but what's going to happen when you're not here? You're not going to be able to make that decision. So why don't you make that decision now so that when you're not here, they don't have to go through all kinds of trouble. And then the next example I'll give them is, what does it mean when you're not here and they have to go through all this trouble? Well, if you have 3 kids and they're all fighting about whatever their inheritance is or whatever the situation is, they don't get to make the decision either, because now you've taken it out of their hands. Now it's got to go in front of a judge. So again, it goes back to education, and you don't just tell them, look, it's the best thing for you to do. That's not education. That's you just trying to pass the buck, right? This is what happens. If you don't do this now, you're capable, you're able to do it, somebody else, which is a stranger who doesn't know you or your children or your grandchildren, is going to make the decision for you. And is that really what you want? So again, I think like anything else, education is key.
Yeah, I agree.
Stephanie, this is Isabel. I'm sorry I had a problem with my mic before, but I just wanted to comment that Al is right on point with his last comment about telling people that, someone else will make the decision for you if you don't. But can you hear me?
Yes,
Yeah,
we
hear
can.
you just fine.
Okay. But, I guess I have a little bit of a different situation than Al does. It's kind of funny. My parents are from Spain. I'm first generation. And my mom's a widow now. And I went through a lot of experiences with my dad, who was a stroke survivor. But the thing is, like, in terms of providing deference to doctors, oh my God, my mom doesn't trust any doctor. And by the way, she lives with me, and I go with her to all her appointments. And if she has to go to the hospital, I'm right there also. As a matter of fact, all the healthcare providers, they call me instead of my mother, but it's been like pulling teeth trying to get her to just sit down and go over with me, advanced directives and, estate planning. And it's my God. It's something else. I can't begin to tell you.
The old saying, it's tough to teach an old dog new tricks.
Yeah, listen, I'm going to get it done, but it's just really difficult with her because she's very stubborn.
Well, you sound like you have a world of patience, which is very important. And it can be hard when the spouse dies. I think we all know that from being in our respective professions. And here she is, the surviving female, and that can be very different and very difficult.
No, that's true.
Well, I want to again thank everybody for contributing and taking time to be with me today for the webinar. I hope you will all join me next Friday, June 26th at the same time, 12:30, for my webinar on 5 misconceptions about wills and probate, know the myths versus the facts. And you can go directly to my website, www.fl-elderlaw.com, to register for next week and future weeks. So with that, I want to wish everybody a healthy, safe, and fun weekend. Thank you for being with me.
Thank you. This was great.
Have a great weekend, ladies.
Content.